Hi, my name is Melissa Tran. I'm a PhD student with the Restore team at the University of Colorado Anschutz Medical Campus. Today, I'll be presenting a project entitled Home Health High Intensity Rehabilitation Elements Influencing Older Adult Recovery of Physical Function After Hospitalization. I would first like to acknowledge the co-authors and the funding we received from the VA and the Eunice Kennedy Shriver National Institute on Children Trial and Health and Human Development. I do not have any disclosures for this presentation, and the contents of this presentation do not represent the views of the U.S. Department of Veterans Affairs or the U.S. government. This project was also supported by the NIH Research Grant 232, funded by the National Institute on Aging, as well as a PODS 1 award from the Foundation for Physical Therapy Research. So just to provide a little background, as many as 46% of older adults experience a decline in ability to perform activities of daily living after hospital discharge. This leaves more than 3 million annually to receive home health care services after hospitalization. So the physical therapists and the interventions delivered during this time play a crucial role in facilitating older adults' recovery after hospitalization. The Restore team recently completed 2 randomized controlled trials that recently compared high-intensity physical therapy and usual care in the home health setting. And what they found is that there was no difference between these 2 study arms in looking at their change in physical function in the 60 days after hospitalization. However, we know factors such as the number of sessions attended, whether or not the session was completed in full, the amount of resistance used, as well as whether or not a patient progresses throughout their care can influence their recovery response. So the question still remains, what treatment elements influence recovery response after hospitalization? So the study purpose of this project was to describe treatment fidelity of a high-intensity approach and examine whether rehabilitation elements were associated with change in physical function 60 days after hospitalization. Just to get on the same page on what we mean by treatment fidelity and rehabilitation elements, we define treatment fidelity as the degree the treatment was delivered as intended. And we looked at it through 2 domains. First, adherence, or the delivery of intervention, and secondly, dosage, the amount of intervention. The rehabilitation elements that we identified for each of these domains include the number of visits, so how many sessions a patient attended, and number of session components, or how much of the session was the patient able to complete. For dosage, we looked at whether or not an exercise was performed on the floor, believing that during the session to perform an additional floor transfer might be more challenging, and whether or not there was progression between each session throughout that patient's episode of care. To do this, we did a secondary analysis combining data from those 2 randomized controlled trials, and we looked at patients that were referred to home health care after a recent hospitalization. And so this included older adults over the age of 65 who had 3 or more comorbidities. We followed these patients from baseline to 60 days after hospitalization, and we only looked at the high intensity arm of the studies, and that included a total of 133 older adults. These older adults were prescribed a total of 12 visits throughout their 60 days of care. To measure their physical function change, we performed the short physical performance battery, which is an assessment that looks at standing balance, walking speed, and a 5-time sit to stand. This composite score totals to 12 points being the maximum. So the higher score you get, the higher physical function you have. For these high intensity sessions, we looked at a total of 6 components covering 3 domains: strengthening, gait training, and functional activity. For strength training, the 3 components or exercises that we performed were leg press, hip extension, and a plantar flexion exercise. These were all dosed to an 8 repetition maximum with failure on the 9th repetition for 3 sets of 8 repetitions. For gait training, we performed stepping and an obstacle navigation activity, and these were dosed to a high intensity by increasing the complexity, speed, and accuracy of the task. Lastly, there was one component for a functional activity, and this could be bend mobility or transfer training. And this was dosed to a high intensity by modifying their environment. So, for example, if performing a sit to stand transfer, the surface of the seat might be lowered to make it more challenging. For this study, we focused on the leg press exercise, which was performed on a portable shuttle where the resistance could be changed using resistance bands so they could be added or taken off. And this leg press could be used while seated or laying supine on the floor. A quick summary of the population that we looked at for this study. Again, there were a total of 133 older adults included. They had approximately a 5 out of 12 on their baseline SPBB score, which is quite low. A cutoff of 10 out of 12 points indicates having an increased risk for mortality. A lot of these older adults were discharged directly from the hospital, but we did have a portion that were referred to home health from skilled nursing and one from acute rehab, and a handful were missing as well. These are some of the common health diagnoses that were present in this population as well. What's important to note is that the average participant did have 5 comorbidities, so they were quite medically complex. For the results of our study, we found that participants attended an average of 11 visits. They received an average of 89% of those 6 components. 80% of those participants progressed in leg press resistance, and 44% performed those exercises on the floor. To answer our original study question, we performed a univariate logistic regression and found that the number of visits and the number of session components were associated with changes in SPBB from baseline to 60 days, all with a p-value of less than 0.01. We did also find that baseline SPBB was associated with physical function changes as well, and that someone with a lower baseline SPBB was associated with changes in their final SPBB. And this might be that someone with lower physical function might have a greater capacity for change over those 60 days. So in conclusion, high intensity treatment elements that were associated with changes in their SPVB scores in the 60 days after hospitalization included a higher number of visits attended, greater percentage of exercise components received, and a lower baseline SPVB performance. Completing more sessions and performing more of the prescribed activities were associated with greater gains in measures of physical function. Interestingly, the progressing the leg press resistance or the exercising on the floor were not associated with gains in physical function for the high intensity group. Therapists delivering high intensity exercise should educate patients and encourage them to complete their visits and to complete all aspects for improving their physical function. I would like to thank the Restore team at the University of Colorado Anschutz Medical Campus, as well as the Berkeley Home Health team and patients that participated in this study. If you have any questions, please feel free to reach out to me. My email is at the top of this slide, melissa.tran@cuanschutz.edu. And I appreciate your time and listening to this presentation. Thank you.